one for every evaluation form. Is that okay? Is that a deal? Then, of course, the checkout in the hotel. People who leave today, you can check out until 12 o'clock. And I've said it before, I've seen people writing and taking pictures, but all presentations will be probably next week on the CEP website. And Miriam told me that she will send an email about that. So that's it. Kieran, the floor is yours.
Thank you, Wilhelm. So, we had a very long and productive day yesterday. I think so far we have talked a lot about the multidisciplinary nature of sexual abuse. That we think about community integration, we think about treatment, we think about assessment, we think about policy, we think about practice. It's all intertwined. And we've got two really exciting talks today, really highlighting some of the challenges, but also some of the real benefits, and thinking about the way that we work with some of the men that we have on our casebooks. So I'm going to say some stuff later on, like reflections on the conference, but I think let's just get into it. So it's my very great pleasure to welcome our first speaker up. Vinike, if you would like to come up and do your presentation. Thank you.
Oh yeah, this is definitely too far from my laptop. I'm used to have my laptop in front of me, and it has sort of a presentator mode, so I can see my next slide on, so I know where I'm actually going with my story. So I try to turn it this way. So if I lose track of my own story, well, we'll pick it up somewhere. I'm going to talk about sex offender treatment, who, what, and how. Or basically, I'm going to talk about the goal that we all have is to stop sexual abuse and what might work to do that. Treatment is only one of the things we can do to do that. It's the way we stop reoffending. We know that not everybody is at a high risk to reoffend, so it's a small part of sexual abuse that we can stop that way, but we can still try. How can we stop offenders from reoffending? What is one of the principal ways to stop offenders from reoffending? Nobody? No? Punishment is pretty good. So I work in a treatment facility, and therefore people always think that I don't believe in punishment, but punishment is pretty good. And for most sex offenders, punishment is also enough. And that can be a judicial punishment in the form of a prison sentence or whatever, but it could also be being punished by a parent or by someone you admire, or even the biggest horror for today's young people, being unfriended. You know, if you've done something that is really unacceptable and people will unfriend you, you will feel that as a serious consequence, and that might change your behavior. Punishment has a psychology behind it. If you want to learn through punishment, or unlearn, it is most effective when, and I stipulated it already yesterday, if punishment is consistent. Everyone who has children knows this. You have to be consistent. What they cannot do on Monday morning, they also shouldn't be able to do on Friday afternoon after you had 2 glasses of wine. So the bad behavior should always have consequences. We should catch our sex offenders, or if not catch them, if we are aware of anything that we think is unacceptable, we should act upon it. We should tell them. Second, punishment works best if it's swift. It has to follow the offending behavior as quickly as possible. So the judicial process should be as quick as possible. It is not, but there's a lot to gain there. And third is punishment works best if it's somehow related to the offense. If you make a mess, you're forced to clean it up. This works a little bit better. So there may be routes to alternative punishment or restorative justice. although a punishment should hurt, preferably not physically, but people should be able to feel it as a punishment, there is very little relationship between a penalty increase and recidivism decrease. So a painful punishment to an extremely painful punishment, that does not really help. This picture is fake, don't worry. So this should work about as good as this. And we have a lot of people in our treatment facility who had a childhood like this. There's nothing punish-wise that we can do that will make any impression on them anymore. For those for whom punishment does not work, more punishment does not work either. It sounds really simple, but somehow it's very hard to understand. It's like telling a psychiatrist that this and this medication doesn't work for the patient. What do they usually say? You should try and double the doses and see if it works. So that's what we do with punishment. Is 10 years not enough? Well, then give them 20 years. That make them learn. But in general, it is, if punishment doesn't work, more punishment doesn't work either. We have to do something different with the people who need more than punishment, who are not able to change their behaviors by themselves. And for all the possible benefits of punishment, rewarding good behavior is almost always more effective. This is a bit complicated. See if I can.
The two pigeons are at either end of the small ping pong.
The voice you hear is Mr. Skinner himself, who taught two pigeons to play ping pong, simply by rewarding them if they make a point. You can see, if the ball drops off on one side, he gets to eat.
It's a real game.
So you can.
Pigeon is reinforced for a cross-court shot if that is what gets the ball past his opponent.
Reinforcement of good behaviors. Like pigeons have like 2 brain cells. So imagine what we can learn people by just rewarding the behavior that we do want to see. Which is basically what we do in treatment. Entice to conform, it says here. What you try to do is invite people to conform to the norms of society and reward them if they do it. Treatment will never work if you tell people you have to work really hard here for 10 years and then we will not let you go. So there has to be some kind of reward in the future. So we can try to reduce recidivism by treating people who are not sufficiently helped by punishment alone. There are a few rules, the Andrews and Bonta what works rules for good treatment or for your forensic treatment to be most effective. I usually picture it as 3 open doors, but because it's like kicking in an open door, it's not that complicated. Who should we treat? What should we treat? And how should we treat it? Who should we treat? The offenders who need it most. Higher risk needs more treatment. It's like almost insanely logical. What should we treat? The things that are related to risk. Because if we want to lower risk, we better focus our treatment on the factors that are related to that risk. How should we treat them? In a way they can understand, the way the offender gets. It cannot be more simple than this. We talked a lot about risk assessment, specifically yesterday. Higher risk requires more intervention, more intensive intervention. And we'll talk a little bit about the other 2 as well today. This is Carl Hansen's schedule on risk levels. Risk level 1 is the low risk. Those are pro-social people who have made a mistake. And the risk level 2, there's minor concerns. Risk level 3, typical problems. It's average risk, typical problems for individuals in trouble with the law. Risk level 4 is chronic rule violations with very few strengths. And then officially there's a category 5. Those are the people who are so high risk that they are virtually certain to reoffend. But it turns out that sex offenders, that there are almost no sex offenders who reached that 5th level. So he made up level 4A and 4B, in which 4B was more and more severe than 4A, but not quite as serious as level 5. And this is about the amount of treatment that we think people need. In level 1, no intervention. 2, mere case management. In level 3, the average sex offender would need about 100 hours intervention. and change-focused community supervision. And level 4 and 5, or level 4A and 4B, need 200 to 300 hours of serious treatment and a cascade of services, as he puts it. So there's a lot to do there. And if you treat them well, they can go down a level. And if you're lucky, they can go down another level. And if they get old enough, at least that's what Carl Hansen says, they will all end up in level 1. So you could also just wait. No treatment, and certainly no intensive treatment for low-level risk offenders is an important thing, because it's a waste of resources. You will have to treat a lot of people who are very low risk to reoffend. But also, it's possible that you make things worse. I've showed this yesterday in the workshop. This is from Lowenkamp and Latessa research. These are all treatment programs, and this is their effect. A negative effect means it makes recidivism worse, and a positive effect means it makes recidivism less. For high-risk offenders, you can see that most of the programs that they research had a positive effect. But for low-risk offenders, you can see that those same programs, most of them were detrimental, made things worse. Only a few of them had a small positive effect. So treating low-risk offenders intensively might not be a good idea. The suggestion that they make, what could be the reasons for that, is that low-risk people in intensive treatment often get disconnected from the protective parts of life. They're house tree animals, we call it, huisje, boompje, beestje. Low-risk offenders often do have a large protective part of their life, which is why they are low risk. And if you disconnect them from it, it could actually increase their risk. Another problem is that in treatment groups, they may get into contact with high-risk offenders, and that's apparently not good for them. So if you want to treat low-risk offenders, and we do in the Netherlands as well, because people find it very difficult to say, you don't need treatment, just, go on with your life. We have faith that things are going to be good. And the judges also find it very difficult. They want to do something. They want to impose something. And if not punishment, then let's do treatment. Better to be safe than to be sorry. So what we did in the Netherlands, at least at our outpatient treatment facility, they made a separate treatment program for low-risk offenders, which is very short, as to not disconnect them from the rest of their lives, the protective part of their lives. And it are separate groups, as to not bring them into contact with high-risk offenders. So that's a very practical solution for this problem. It would be better to advise no treatment, though, for this group. If we skip to the door to the far right, the responsivity door, the treatment must be offered in a way that matches the learning style of the offender. So the offender has to be able to get it. I don't have the literature for this, but I was once told that therapists in general, psychologists, are very good with language. They're like up here, as to where our patients are down there. They're often handicapped. So talking might not be best for all patients. There are two kinds of patients' responsivity, traits of a patient that require us to do special things. There's the changeable factors that can actually be a treatment goal in and of themselves. I'll get to that in the next slide. And we have the more structural handicaps that require us to change the treatment, because we cannot change the patient. If we think about treatment targets, responsivity factors that are treatment targets, sometimes treatment of responsivity factors is necessary to enable treatment of the risk factors. I already gave an example like 1 minute ago. I think it's one of the, this is even a better example. Motivation. If someone is not motivated for treatment, you should work on that first. In and of itself, it's not a risk factor, but if someone is not motivated, you won't get to the risk factors. So that's a very important part of treatment. ADHD, disorders, you could treat them with medication, but you could also have your treatment program be really versatile and full, as to make it more acceptable for them. severe psychiatric problems. This is where the disorders come in. Disorders in and of themselves are not risk factors, but sometimes you have to treat a disorder to get to the risk factors. If someone is really psychotic, you can't treat them. If someone is really depressed, you can't even start your treatment. So you need to deal with these things first. The other things are the structural handicaps. Sometimes the treatment needs to be adjusted to reach the patient. That's where I gave the example earlier. What I think is the clearest example here is intelligence. Developmentally disabled patients cannot be treated with extensive talking therapy. That's just way too difficult. You have to adjust the level of your treatment. And what I think we can invest in way, way more is non-verbal treatment, to try and give them some exercises or maybe even computer games or telephone apps that will assist your treatment without the excessive use of words. That's what I say, talking and talking and talking. Okay. There's also people who have a defective emotional life, like people with pervasive developmental disorders or high levels of psychopathy, where you cannot count on the relationship between patient and therapists to grow. So you have to adjust your style of therapy to that, be more stringent, be more clear. But also, what is a big problem in our facility, narcissism. You cannot, if someone has a severe narcissistic problem, you cannot break through that and think, what we always feel like we want, get through to him. You are not that special. It won't work. What works way better is to find a way around it, sparing them a little bit, give them an honorable way out. As for instance, the pedophilic offender who said to me, it was the 80s when I committed my offenses. We didn't even know it was bad for the children back then. Well, I could have said, you could have guessed. But I told him, yes. And if you would have known, then I would have never done it. And now you know, yes, so I'm never going to do it again. So and then you have reached the same point where your goal is the same. And often there is no need to cut someone down to get there. It's a difficult path, specifically with the narcissist, because they tend to go their own way. It's a big challenge. There's also talents among our patients, believe it or not. Even with we have very serious patients in our facility, but lots of them have a really good sense of humor, and you can use that in your treatment. These are, I could give examples, but I don't want to have them live streamed. So responsivity requires customization. This is why we need to look at the patient and sort of adapt our treatment to every individual patient. It has to do with responsivity. How do I reach this person in the best possible way? But the core of treatment, of course, are the need factors, trying to influence the dynamic risk factors, or the most important dynamic risk factors if your time is limited. So we know what the dynamic risk factors are. We have instruments to assess them, and these are the main treatment targets. You can also pay some attention to personal needs of patients. You can, if they have something they really feel bad about or suffer from, it's kind of strange to say, well, you might be really unhappy, but that's not a risk factor, so, we don't care. This is not why people become therapists. You want to help people. But what is important is that you are aware that you are now treating a non-risk factor. And that is, it's completely allowed, but it shouldn't be the main part of your treatment. Your focus should always be on or return to dynamic risk factors. Another thing we tend to do in our facility is to think of the people that come in are like crooks, and then they go through our hospital and they come out as model citizens. And we would, be very pleased if they dress well and cut their hair short and have really good relationships with the relationships we would want to have ourselves. That doesn't happen, and that's completely unnecessary. We don't have to make model citizens of our patients who brush their teeth 3 times a day. What is important is that you let go of all the things you might want for them and return again to what they need to achieve to have their recidivism risk reduced. Not everybody has to be the same person. So criminogenic needs are key. And it's hard to stick to that because, like I told yesterday, the hardest thing for people like, and I think it's probation workers and therapists are completely equal in that aspect, is the things you must not do, the risk factors you shouldn't weigh, the treatment that you shouldn't advise, and the parts of treatment, the problems that you maybe shouldn't help someone with, or the things that you shouldn't change about them. I think we find that way harder than the things we have to do. So what is it that we actually treat when we treat sex offenders? It always takes a while for this one to sink in. I think it's a really funny one. Psychotherapist is one word. What do we treat in sex offenders? What makes them different? What are the main risk factors, not like the list of individual risk factors? And to explain that a little bit more, I would like to introduce the sexual motivation cycle for normal sexual behavior. And it starts here. There's a competent sexual stimulus. Basically, there's something that turns you on. This is where sexual behavior starts. It starts with the stimulus. There's something that turns you on. Your body, your brain, your most important sexual organ will react with liking and wanting. It will say, I like, attractive. And it will say, I want. And it prepares your body for action. You want to go there and do something with it. If you inhibit, you will leave the circle. If you disinhibit, you will actually do something. And what you do is you approach the stimulus. And what you look for is a slightly stronger stimulus. So this process starts out very, very small. And before there's actual sexual action there, you've gone through this circle many, many times. Sexual motivation is a process, and I think a much longer process than we tend to think. First, you see someone you think might be nice. You try to chat someone up and maybe get her into a situation where you can be more sexual, less clothes, more clothes, etc. And we want this process to make a certain progress at a certain pace, not too slow, but preferably also not too quick. So it's a very delicate process, and you go around the circle many, many times. The physical sexual response cycle for men, so erection, I think you've probably all seen this, starts here, excitement, then you have the plateau, and then you go up a little bit higher for orgasm and resolution. But within your brain, it has already started way before there is a visible erection. You have a lot of initial sexual arousal that already drives you in the direction of the stimulus. I think it becomes clear if you look at grooming behavior from pedophiles. And they will tell you, no, it's not sexual. I just like to be in the playground and on the slides with the little children. But you kind of get the feeling that it's a bit sticky. It's sort of sexual, but not experienced as clearly sexual. If you go through the circle, in the end, hopefully you will reach a point of sexual gratification, and then you have acquired an experience with precisely that stimulus. And this process will make that stimulus a little bit more enticing the next time you come into contact with it. It raises the salience of that stimulus. So that means that experience matters. Learning processes play a part. And my experience is that especially Americans find that very hard to believe. They tend to believe that you are who you are when you are born, and the rest of your life is merely rolling out who you are anyway. Where it is my firm belief that what you do will change who you are. And I think you can hear that from the stories of many, specifically people who download child abuse material online. Most of them didn't start out that way. They just got into it, and they realized that they liked it the more they got into it. So by doing stuff, sexual stuff, you are actually changing who you are in a sexual way. It's not a limitless. There are certain certainties and things that will always work. Like for this stallion, will always get sexually aroused by the smell of a mare, even though he's probably able to see that this is not a mare. But it will always work. That's biology. But you can also teach rats, like Jim Faust has done, to prefer to have sex with a jacket on. And he did that by giving them positive experiences with the jacket on and negative experiences with the jacket off, and they preferred having sex with the jacket on. There's no biological reason for that. So there's a little bit room for movement there, and we know that because every person has a certain type that they find attractive. You are not born with a preference for redheads. That has to do something with experiences. And in the 60s already, Rahman did a research where he paired pictures of boots to sexual stimuli and got to the point where people got sexually aroused if they were presented with pictures of boots. So there's some conditioning is possible there. There's room for change, although I think that some boots would do better than others. If we look at sexual motivation cycle and sexual offending behavior, and let's say we take a normal stimulus. What is normal for the average man to be aroused by? I would say it's like a young, attractive woman. How young? What percentage of men, let's say what percentage of straight men, grown-up straight men would ever find a 13-year-old girl sexually attractive? Like not maybe most attractive and not all the time, but what percentage would be able to find a 13-year-old girl sexually attractive? Round and about. 70? No? It's about 100. There's nothing weird about that. This is about, more or less about the age that girls become sexually attractive, and somehow, coincidentally, it's also the age that they become fertile. Maybe the two have something to do with each other. So it's not biologically strange to be sexually attracted to 13 or 14-year-old girls. That's what I told a patient, and he repeated that to me in his the next talk we had with a lot of other people present, and he said, "Yeah, but you said it's not biologically strange to find a 13-year-old girl sexually attractive." And I said to him, "Yes, but I also said you are an asshole if you act upon it." "Oh yeah, you also said that. Yeah. And it's a way different discussion that you have with this guy from telling me you're not a pervert, you're an asshole, and you must not be an asshole. And somehow they find that much easier. I don't know why. So 13, 14-year-old girls are generally found sexually attractive. You can also see that if you look at the average age of victims of sexual violence. Most victims are around that age, 14, 15. There's a peak there. Even if you break it up in different offender ages, you can see that the older offenders have a bit of a wider range in victim age, but the peak is consistently at around 14 years old. So not only are 14-year-old girls sometimes sexually attractive, if you let go of all social rules and become an asshole, they might be the most attractive. At least that's what Felsen and Cundiff conclude. So a normal sexual stimulus. If we want to treat someone who's an offender against let's say a normal victim, what do you think the emphasis of treatment is going to be? What do we need to achieve with someone if we look at this circle? No. Inhibition. That's what we work on. You might like it, you might want it, but you're not going to do it. You're going to inhibit. You're going to get out of that circle. That's what we work on. And at high risk to reoffend are those who are disinhibited, who have problems with inhibition. In three ways, basically. You have state disinhibition, intoxication. A lot of sex offenses, in particularly sexual assault and rape, are people who do that are intoxicated. under the influence of alcohol or drugs or both. Also, people can be disinhibited by nature. They can be impulsive. So you have trait disinhibition. Or what I've called here choice disinhibition. They might be able to inhibit, but they just don't care. Antisocial traits. These are the most important factors for most sex offenders to work on in treatment. Learn to behave differently. Learn self-control. And it's entirely possible. You can, by practicing and by therapy and also by medication, if you want, you can train your brain, your prefrontal lobes to become stronger and to be better inhibited. There's also another way that we work on a lot in treatment. I call that the Temptation Island paradigm, because my colleague Vivienne de Vogel, she has 4 children, a lot of laundry to do, and while doing laundry, she watched the program Temptation Island. Anyone know that? They take one half of a couple and put them in very, very difficult situations, and they all fail. And she said, we're having lunch, and she said, you know, if I imagine like my husband sitting there in the hot tub with a bottle of champagne and 2 gorgeous women all over him, and he wouldn't do anything, I would think there was something wrong with him. But her husband loves her, and what does he do? Exactly, he doesn't go to Temptation Island. Don't start the program. Don't get yourself into a situation where you might be tempted. So that's what we try to learn our patients all the time. If you're a pedophile and you have to go to the zoo, don't go on a Wednesday afternoon when all the schools are out. Like if you want a job, fine, but not be a child photographer. That's not a good job for you. So you want to keep people away from entering the circle as to relieve the pressure on their inhibition. So now if we look at deviant sexual offending, so offending against children, really under the age of 13, significantly under the age of 13. So how many grown-up men would ever find a child under the age of 12 sexually attractive? It's not 100. So you can guess lower. 30? No? If you ask them directly, there's less than 1% who says yes, because they often think that you mean, do I have a preference for that? But if you don't look at preference for children, but mere interest, or people who sometimes fantasize about it, some research goes as high as 20%, somewhere between 10 and 20. So that's not the majority. It is a bit odd, but it's a substantial minority. There's your possible child pornography downloaders. But let's take something that's really, really rare. People who get sexually excited by smelling the farts of another person, preferably a beautiful woman. So if you would treat this guy, and he would say this was offense behavior and you wanted to stop it, if you were to treat this guy, where would the emphasis of your treatment be? What would you treat? Yeah, exactly. You can say that out loud. Exactly the same. Why not? Why not teach them exactly the same thing? You might like it, you might want it, but you're not going to do it. Exactly the same. Stay away from it. I don't know exactly. It's kind of easy to stay away from this one, but stay away from it. Don't get into the situation where you might be tempted. The treatment of deviant sexual offenders basically, largely, is exactly the same. And basically, largely, they can learn to behave differently. It is hard to learn to behave differently. I don't know if anyone of yours has started a healthy, sportive life recently. It is hard to change your behavior, but it is possible. But also, we're kind of interested in this arrow. Is there something we can do to make this odd or forbidden stimulus be not arousing to this patient? It's a part of treatment that we have almost given up on. I don't really know why. I think it's important to get that back. But you could also try to stop that from happening, to stop that stimulus from making someone aroused. What is one of the ways that to cut the cord, as it were? One of the ways we try to do that is by medication, anti-androgens. What you do is lower or nullify the sensitivity of the sexual system. Testosterone sensitizes the dopamine pathways, and those are the ones related to wanting. So that make you actually, you like something, you want to go there. If you have lots of testosterone, your need to go there is much higher. If your testosterone lowers, you will still like what you like, but you won't feel so much need to act upon it. Of course, this is not specific. And that means that if you put a medication in your sex offenders, yes, they won't have the deviant arousal so much, but they also don't have the normal arousal. It just stops completely, which is not always what we want. You would want to be more specific. Other things, therapeutic things have also been tried in the past. Aversive conditioning, also done, I think still done in some American states with homosexuals, like this guy. You get to see pictures of naked women with lovely music and the scent of flowers, and then he gets to see pictures of naked men, and he gets something induced that makes him vomit. And the idea is to then attach the stimulus of naked men to vomiting and to make them less attractive. Well, it didn't work for this guy because he said, it's a year ago, I'm still as gay as I ever was. Only when I meet this guy on the campus, I tend to throw up. So it might work for some people, but they have to really, really want it. And you never know where the effect is going. Another thing that's been tried is satiation therapy, like, masturbate on your favorite fantasy beyond pleasure. Just masturbate to it over and over and over again, and then it stops being arousing. A lot of those things are from the past and a little bit weird, but they have all known some successful cases, at least. A new thing that we're trying in the Netherlands is EMDR treatment. You're familiar with that? Usually it's been used for traumatized people, and you think of the trauma and it makes you feel, ugh, and then you do the eye movements, and it sort of it takes away the emotional load of the memory. And we've been trying that with exhibitionists, and in the positive way. So make them think of what is the best part about exhibitionism. Usually they'll say, it's the moment where they see me naked. Oh, well, think of that moment, and then follow the fingers, and then progressively it gets less and less exciting. You can take that away. It is possible if someone really wants it. But the research is still ongoing. But I had an interesting story from one of the patients who came in for the third or fourth session and said, something's going terribly wrong with this treatment. It doesn't work at all. And the therapist said, why? Yeah, now the whole feeling is gone. That could not have been the intention of this treatment. Yes, it was. But what happens a lot of the time with people with deviant interests is that taking away the deviance is actually taking away everything. Because that's their only interest, and that's their only connection to sexuality. And often people don't want that. They don't even realize they don't want that until they have something that might work. So you have to agree with the patient. Do you want control or do you want cure? And if you'll find out that a lot of people will want control. They don't want to give in to their temptations and get into trouble, for instance. But they do want to be able to get sexually aroused. So they don't want it to go all the way. And you have to be certain on where people stand to be able to treat it in a successful way. Because otherwise you might treat it, but it will just come back later. Because it's their route to sexual arousal and sexual gratification. So does treatment work? If we try all this stuff, does it really help? Most of the treatment is cognitive behavioral treatment, but you can also look at the other kinds of treatment. Does it help? If we look at international research, I'm not going to be like cheering really loud here. It kind of works. It helps a little. It reduces recidivism somewhat. And that's, of course, because recidivism rates are not high for sex offenders in general. And by treating them, the lower numbers get a little bit lower even. So it's not really that impressive, but it does work. Hansen and Borgen and Helmus and Hodgson in 2009 have showed that the risk-need responsivity principles are also really important with sex offenders. If you treat them according to those rules, you will have a larger treatment effect. Schmucker and Leusel was the most recent meta-analysis, and it also showed effects of treatment on recidivism. I did a Dutch study specifically for our inpatient treatment, so the really long-term, heavy sort of kind of civil commitment treatment. 90 inpatients compared to 176 untreated offenders who just went to prison and came out without any form of treatment, but I did match them on their risk levels. 12 plus years follow-up. These were the recidivism rates, sexual recidivism for the treated patients. So still low didn't recidivate, and the high ones recidivated considerably. But compared to those who were not treated, you can see that it was a lot less. And more specifically, it was a lot less and significantly less in the high-risk category, which again indicates that the risk principle is really important. This is a very intensive, long form of treatment, and it is specifically meant for high-risk sex offenders. This is where we can expect the most, the biggest effect of our treatment. But there's also a new meta-analysis from Theresa Gannon and some others. I think Mike Olver is also involved. It isn't even out yet. And I know why, because I'm kind of stealing her results, but I didn't want to keep it from you. She has presented on it herself a couple of times. She found that treatment reduces recidivism rates by roughly a third. So that's okay. And she also found in her meta-analysis that treatment is more effective if it's provided by professional therapists. So we should have the treatment done by people who are educated to do it. That's really important. And another, what I think is the most interesting finding, treatment works better if it includes some form of arousal conditioning, like the weird stuff that we just talked about that made everybody giggle. It does something. And it's not entirely clear what it does, and it doesn't work for everybody, but treatment that pays attention also, so not only to inhibition and avoiding the stimuli that you like that are illegal, but also treats the arousal itself. Can we somehow make you not feel aroused by this that you shouldn't be aroused by? Apparently, it helps to add that to your treatment. I think that's interesting. So, if I want to wrap it up, I'd say learning to behave differently is entirely possible, even for sex offenders. This is what I always say if people, like, if I could ever get to talk about my work at a party, they say, yeah, sex offender treatment, that doesn't work, does it? Yes, it does, because you can learn people to behave differently. I think we could see the effects better if we wouldn't take as an outcome measure recidivism, yes or no. Because you know that if you are changing your behavior and have decided to only eat healthy food, there comes a time when you will eat that cake or those French fries. But it might just be once and then not again. So I think we get more information if we look at the number of recidivism or the seriousness of recidivism. But anyways, people can change their behavior. Learning to feel differently, that's a whole lot more difficult. But it may not be entirely impossible because targeting the deviant arousal appears to help a little bit to increase the effects of treatment. But you always need to have informed agreement with your patient as to what you are doing. Be honest, have the agreement that, no, it's not strange to find a 14-year-old girl attractive, but yeah, you shouldn't do anything with that. Be honest, if I take away your desire for your deviant sexual arousal, there may be nothing left. Is that what you want? And if not, we best handle that now. Maybe there should be some sort of mourning therapy to realize, like for pedophiles, that the way they want to have relationships or sex is not going to be possible for the rest of their lives. They're going to be alone in that aspect. And that's a very important part of treatment. You have to agree with your patient about what you are doing. that also increases the chance of achieving anything. This was my talk. This is my email address. If you have any ideas on interesting research, I'm always open to suggestion, and you can reach me there. Thank you.
So, thank you, Vinike. That was really good and really interesting. So we have some time for questions. I have got a microphone, so if you do have questions, you will need to speak into the microphone. So maybe I'll ask one to start with. One of the things that we've heard a lot about over the last couple of days is internet-only offenders as opposed to contact offenders, and how that's challenging our conceptions of what we do. So I was just wondering about your insights about how you start and what you look at when you're dealing with internet-only people. So people who you don't think have went on to commit a contact offence, but are downloading people. What is the thing you think that you need to start with and start thinking about when they arrive with you?
Yeah. People are very complicated because they don't just, get aroused in the face of a stimulus or not. They can also think about it, remember yesterday and look forward to tomorrow. So they can actually try to seek sexual arousal. And I think one of the reasons that people tend to seek sexual arousal is to increase their arousal levels, as to make themselves feel better. And I talked about this with Laura Kula yesterday. She said for the online offenders, emotion regulation is a huge problem. These people are usually unhappy, to say the least. And I think that they might look for this pornographic material as to sort of elevate the levels of happiness, which is why they don't look up the pornographic material, masturbate to it, and go on with the rest of their lives. Because if you ask them, basically, there hardly ever is a rest of their lives. So what they do is they download the material. They say, oh, that's a nice picture. And then the next one, oh, that's a nice picture. And this goes on for hours and hours and hours. So it's a way of regulating their own emotions and keeping themselves at a happy level. However, the crossover to hands-on offending is really, really small. So I think it's a separate group, and for a large part a new group that came across this material online, and more often than not realized that they liked it when they came across it, when they went to the regular porn, and then young and younger. Young is like the most often used search term, I think, or the second most. Young, younger, youngest, even younger, and they progressively slide into that illegal area and get stuck there. So what should you do when you treat them? Find alternative ways to be happy. Get a life. It's the really short version of it, I think.
Well, tapping into that, the Good Lives model is starting to take a foothold. What do you think of the Good Lives model as an additional model or an alternative to the normal cognitive behavioral model of treatment?
I like the Good Lives model. I think it's very good to have positive goals, and it's also very good to ask people, what function does this offense behavior have for you? Specifically for the downloaders. That's a very important question. I do think that you cannot do treatment with a Good Lives model only. You have to keep the risk factors in mind. Because even if people find a good positive goal in life and a positive way to reach it, if you've been there, specifically the addictive internet, and the internet is always there, that is a route that is still lying there, and you have to be really aware of that you don't slip back into it. We see so many patients who slip on the internet. It's not the end of treatment. We just take them back and we start all over again. But you have to be aware of the fact where your risks lie to be able to avoid them a little bit. But in the meantime, you shouldn't go through life only thinking, oh, there's a risk, there's a risk, there's a risk. It's a good thing to look at something positive that you want to achieve in a positive way. What I do find a little bit difficult about it is that in our facility, we have a lot of patients who don't have many talents. So I think that the good life model sort of bluntly states, you just find your talent and go for it in a pro-social way. And then there's this patient, and I'm like, okay, where are you going? For some people, it's really, really difficult. And sexual arousal and sexual gratification is the only positive thing they have in their life. It's the only moment that they feel happy. So, and then finding a positive goal in life can be really, really hard.
How do we help clinicians who want to help not help? How do we stop them working with the low-risk offenders?
Once they get into treatment, of course, you're going to have to do something. There's somehow I think if it's not risk factors, people should go to regular treatment. If someone goes to regular treatment and says to their therapist, I'm so depressed because I abused my daughter, they're like, oh, don't go forensic. So maybe forensic treatment facilities should have non-risk treatment groups where you treat the other stuff that is not related to risk, but is important to the people. Again, specifically for the downloaders, they're often not very happy. They're not very risky either. They may not download child pornography anymore, but they will drink a little bit more. But if you say, that's not enough for me, I didn't become a therapist for this, I want to have them be more happy and be more socially adequate, etc. I think we could have forensic treatment groups that are not about risk, that are about social contact and etc., making your life worthwhile. Yeah.
I guess that most of the people here in this room are probation officers or working for probation. You are working in an inpatient facility. Now the question is, what are the borders? When need a person to be treated in an inpatient facility, and when what is the contribution probation can make? What is the target group for probation?
In the Netherlands, of course, the probation officers also do the majority of pretrial assessment. So the very, very uber important task of probation is to take care that the right people go to the right level of treatment. So in the Netherlands, we have kind of a large gap between outpatient treatment, which is actually relatively low level, and TBS, which is extremely high level. We're busy creating something in between, like short-term clinical treatment. But you should take care that the right people go to the right treatment. So that's basically, I think, a very important task. And then people who go through the inpatient treatment also get out again, and the probation takes care of them too. So on the front end, by getting people in the right direction, on the back end, by having people under your care who went through all that. I think that's equally important.
And what about the sexual treatment programs that in some countries are implemented by probation?
I would be very careful about that, because also we now have research that really shows that treatment is best provided by people who are trained to provide that treatment, and probation is best carried out by people trained to carry out probation. So it's good to have knowledge about how treatment works and what risk factors are, and keep them in mind while taking care of someone. But I don't think probation officers should provide treatment as such. Also inside our clinic, there's two things that you want to have. You want to have good treatment provided by professional therapists, and you want to have the circumstances in which people feel safe to try new behavior, to try and change. No one under pressure, no one in fear of their lives is ever going to change anything about themselves. So you want people to be safe, and you want to have a positive, stimulating environment to make them practice with what they've learned, so that the seeds of treatment can actually grow. So that's the both things we try to do: have good treatment and have really good circumstances in which people can change, and then bring them back into society really carefully and slowly and step by step. And if something goes wrong along the way, it's not the end of everything. You take a step back and then you go again. It's basically like raising children.
So I've got one last question for you. And so I think we've all experienced the conversations about low risk individuals before. And in the UK, we don't do anything with low risk. But when you talk to some international colleagues, especially in the US, they're horrified. Sometimes when you talk to victims and victim advocates, they are as well, because they're coming from a perspective that this person has harmed someone. So what would your message to us be about how we talk about why low risk people shouldn't necessarily get treatment? Because I think this is something that we all encounter and we all struggle with a little bit from time to time, because we have to be professional and we have to manage this. But yeah, so can you give us some thoughts about how we might negotiate that conversation?
Yeah, in an ideal world, you would always have endless resources to do these things, but resources are a big problem. So one of the arguments is that for every low-risk person that you keep in treatment, there's one less spot for a high-risk person who needs it more. And I think that what tends to happen in the Netherlands, like, for instance, like incest offenders who are at low risk to reoffend, but have committed really serious offenses, really, really harmful for the victims. But these victims, they come forward like 10 years later, and then there's the case, and then the perpetrator says, yeah, I'm very sorry about that. I've got my whole life in order. And the judge just doesn't dare to give them a prison sentence because, yeah, that will be so disruptive, right? Well, let's give them treatment then. At least we do something. And I think you should be fair. You should keep those things apart. You punish people for the seriousness of the things they've done, and you give them treatment to prevent recidivism. And those are two very different things. And I think if you get the punishment right, people will be less worried about the treatment, because if treatment is all they get and they get no treatment, there's nothing. So there's no retaliation, and that also should have a place in the whole process. The resources thing is important. I think the fact that you could make things worse, that's actually really important to me. That's not what you want, but I don't know, it's tough to sell. You're the public policy guy, you tell me. But I do think that the solution that the WAG, our outpatient treatment facility, found was quite elegant, to have like these short, low-risk groups, at least not mix them with the high-risk offenders and keep it really short. Because specifically low-risk guys, because they are relatively adequate, like downloaders, they kind of like the treatment and they're always on time, and it's nice to have friends, and they tend to stay in treatment for a really, really long time. And the therapists like them as well, because you really have the feeling that they listen to you and that they get you. And so it's not only that they enter treatment, they have a very hard time getting out of treatment. And so, yeah.
So I would just like to say thank you again to Vinike. The PowerPoints will be available online. We've got a little bit of a longer break now until 2:45. Those of you like me who haven't packed yet, you have got 30 minutes to pack and check out, and to be back to hear from Marianne about Mosaic and some of the really interesting things that's going on around that. Enjoy your coffee break. Thanks.
So scared that I would be too long, and I was too short.
I think it's always the way with these things. you look at the slides and you see the one thing that you do is that you'll have loads of slides, but then you'll change the picture within the slide. I look at that and go, oh my god, there's 100 slides. But in reality, there's only actually 40 slides.
And I only do the slides and not too much around it. But it's because I used to have a newer version of PowerPoint, and then I put it on the stick and on the computer. And it would change everything, change my arrows in a different direction. So I make extra slides and I prefer to use my own.
Thank you very much.
No, not myself. But I'm she's she did this experimentation and has a research project and she came to me. I was like, this is so great. And she's and we're doing more research. So yeah. Yeah, the Miller protocol, like the addiction protocol, is you have to pinpoint really. So of course, what we did was ask people what their favorite.
But
Well, first they would kinds of measures, I compared like it's very hard to get into
and then afterwards, so I just have to stop. And then all friendly people here, so I think it's Can you there are some problems actually. So because so it's difficult so on my slide. So she, the girl, she might help me just when I come to her. We'll try it now. Okay, good luck. So, mechanism of experience. When you work with them, how to should you start with this behavior or with this experience mechanism or when you experience something, you like you said, this circle. This goes to them, then
Yeah, what experience is that it's very hard for people to introspect, to see how things work.
That's right.
Yeah. What we do is we take the dynamic risk factors and then talk to the patient and say, what do you see as problems? And if you agree, if you have one you agree on, the therapist thinks it's a problem and the patient thinks that's where you start. Yeah. So to first tell us the pre-market.
Yeah, this means that you actually go to the primary, the risk. I think.
Yeah.
The families
Or life history also, of course. Yeah.
Okay.
But I think we start with the risk.
There is no sound now.
If you have more than one, that you agree upon,
Het geluid van de ding moet zo aan.
say how do they
Luister maar.
Yeah. Because that's very
Je
different.
hoort nu op de computer en niet daar.
Often people do not know how they work. That's very important. So that's like one of the first notes, and it fits in between groups.
Feel good and
It's good, right? Yeah.
Yeah, I like that one. But it's only for child. So for rabies.
So I will show it like this.
Yes. And what I like about this model is that it's for normal people
Wil drinken,
as well. How normal sexuality works.
Ja.
And it can
Is erbij ook?
describe how the feminine
Nee, het is nog wat. Oké. Can I get you coffee or something? Ja, lekker koffie. Milk.
This is how you
With
become
milk.
sure. There's no way out of here. There's no
So
normal
this
people.
is what we
That's what I
show.
like about this.
After you see something here, but video we can do
This is how
this
feminine
is, and then you see the part. Yeah. Yeah, and then I yeah.
Yeah, it's not bad.
And then I do it like this after the beginning.
But I like more, this is more sexual. And I think sometimes it helps. If your patient is maybe antisocial or impulsive, you might not need it. But for the
Yes, thank you.
Because often they are.
I always talk too much to little one. Perfect. No? Just perfect. And would you like this? Oh, you can have there are some forwards. Yeah, sure. Kijk, dus je hebt zwart, toch? Ja. Oh ja, dat weet ik natuurlijk. Ja, gaat het lukken met, dus jij zit hier nu, jij blijft hier zitten om die film dan aan te zetten op een gegeven moment. Ja. Dus de laatste presentatie alweer. Ja, snel hè? Ja. Echt te grappig. Ik had even een mailtje uitgestuurd naar de mensen over hoe laat ze worden opgehaald hier en zo. En toen van David Briggs, die met Mike samen deed, heeft alleen als van zijn assistenten. Dus daar heb ik ook steeds mee gecommuniceerd en zo. En die zei tegen mij, super dank je, maar ik weet niet meer of ik David nog vandaag spreek. Als hij belt, dan geef ik het eigenlijk door. Ik zei, joh, maak je geen zorgen, ik heb hem al gesproken. Precies, dus hij weet het al. Hij zei, oh super, en is zijn leds verbeterd? Want ik had toen een lijstje gestuurd van de mensen in de workshop, waar best wel wat letten bij. Ja. Toen had Mike gezegd, nou David gaat wel wat leds doen. En nu vraagt ze dus.
Wil jij die stekker er even uittrekken? Ja. Oh, thank you. Hier. Tomorrow, yes. We try to find our way through the day.
I sent you an email, and you might not have seen it, regarding this afternoon. There's transport to the airport arranged for you, like also the airport. The 3:45 for you and Maria, and well, a third person. Yes. But in the hotel, you can see a car from the patient waiting. Yes, 3:45. Yeah.
And I have this boarding card.
Ah, yeah. Yes. Yeah. Yeah. I'll give you.
Committee. So I used to be in the international committee, but it does no longer exist, and it became the international committee. So yes, I mean, now I remember. Thank you.
Goed verhaal. Prima. Ik ben zeer onder.
Ja, dat is altijd leuk om te horen, vind ik.
Is er een gemeenschappelijke je bent van de
De forensische zorgspecialist, eigenlijk officieel van de Hoeven, maar ik ben ja.
Is er een gemeenschappelijke vergadering tussen reclassering en jullie over wat de taakverdeling is?
Nee, natuurlijk niet. Ja, iedereen gaat zijn eigen weg. Er is al niet eens een gemeenschappelijke benadering over wie er getraind moet worden in risicotaxatie en op wat voor manier. En dat ga ik maandag heb ik een overleg met de rinoman en de reclassering, want wij denken daar toch gewoon anders over.
Weet je wat ik ik vond het werk van de reclassering het is nu een nieuwe directeur.
Oké.
Dus ik heb een beetje nagedacht. En ik merk dat het goedkoper is informatie is. Om te denken van, hebben we het systeem goed ingezet?
Ja.
En zeg maar, wat belangrijk is, dat jij laat blijken dat je er ook inhoudelijk niet omdat je je markt
Nee.
Die gedachte zit er altijd achter.
Ik verklein juist mijn marktaandeel. Ik wil al die trainingen die jullie geven. Ik heb er helemaal geen tijd voor.
Nee, maar ook zijn er welke klanten jullie wel en niet meer.
Ja.
Die taakverdeling waar je het over had.
Ja.
Dat die recruitering moet zorgen dat de juiste mensen in de juiste stroom terechtkomen.
Ja.
En dat ze daarna weer worden begeleid en opgevangen.
Ja.
En alert zijn op terugvallen. Dat is voor ontzettend goed. Nee, ik ben zelf altijd ook voorstander van de recruitering. Het is gewoon compleet mislukt. En ja, dan zit er vaak een gedachte achter van ja, maar de waag die wil dingen binnenhalen. Als je dat Als je dat bestrijkt, dan is het helemaal niet precies.
Nee.
Dan komt dat het beste systeem in.
Ja, nee, maar dat is ook helemaal niet zo. Ja, misschien, je kan niet voor de waag spreken, maar ik heb zeker niet behoefte om dingen binnen te halen. Want er is genoeg te doen.
Ja.
Het is alleen, je zou wat nu dus gebeurt, dat iedereen massaal getraind wordt. En eigenlijk al jaren geleden zijn, moet gewoon
Did you get your video tomorrow?
Yes. She helps me because it's 14 minutes.
Right.
So it's too long just to have segment
Okay.
slide. So she'll help me when I get to that slide. So
I think we all learned from in Manchester today. Don't rely on the internet.
no, that's true. That's true. But I hope it will function. So, can you finish it?
Yes, you are. You are. See, it's so loud.
No,
But it's getting this it's like you go to IANSO and it's mainly therapists and clinicians. You go to criminal justice conferences and it's mainly police and probation. Actually getting a mix of people in the room is really what you need.
and you can feel it when you talk about it.
I think there's a lot to be said from the party about there. It's like all the stuff that we've done over the past 30 years. We've done all the groundwork we failed and it's done this, and then they can see actually you don't need to do all of this. You just need to start
That's
here.
true.
Yeah.
Yeah, that's we learned a lot from the Swedes.
Yeah.
We mentioned that.
Yes. Yes. And if you ignore your next door neighbors, they'll.
No.
And especially since you'll have one in the front row. Yeah.
I'm ready, Marinte. You ready to help me? And perhaps also, if I don't think. Oh, and Marianne, there's a clock there. Did you see it? Yeah, okay.
Okay. So hopefully everyone has checked out and there won't be a moment of realization halfway through Marianne's talk. I have been in this instance before where I was speaking at an event and someone realized they forgot to check out and jumped up and ran out of the room. And I was like, what did I say? It was obviously quite traumatic. And I found them later on and they just forgot to check out. So as we're coming to the end of this, we've got a very interesting talk coming up from Marianne about the mosaic model and how this relates to what we do in supervision and in management. And what you'll have seen, more or less, the theme for today is about treatment and management, where yesterday was a lot more varied and we looked at a lot of different things. So hopefully there'll be some practical advice in here and hopefully there'll be some things to think about as we move forward. So I'm now going to hand over to Marianne and she will do her presentation. Thank you.
Thank you. Can you hear me? First, I want to say thank you very much for a wonderful conference. I have been really delighted to be here. And thank you for a wonderful evening yesterday, where suddenly I was dancing. I didn't know I should make Latvian dances, but this was really a lot of fun. So thank you very much, all of you. Yes, I am going to talk about the supervision model Mosaic that we have developed in Denmark for our probation. It is a general model, supervision model, but so here I want to discuss with you whether it could be beneficial for sexual offenders as well. So I hope you will join me in that and discuss with me. So this is my program. I will start to just tell you short about my background for making this talk. And then some facts, the numbers, how many sexual offenders are there in Denmark and so on. And then very short, tell you about our treatment model for sexual offenders, because it connects with our supervision model. So I hope you have patience to listen to that. And then repeat what are the risk-need factors of sexual offenders. What do we know about their motivation to change? And we have heard a lot about that today. Vinegar told about it, and yesterday we heard of it. And then a little more on sexual offenders' pro-criminal attitudes, which are in focus in Mosaic. and then make Mosaic as a possible supervision model also for sexual offenders. So, and here, when I talk about Mosaic, I will show you a video of a Mosaic session, just to illustrate how the probation officer works together with the client in Mosaic. So I hope you have patience to see that. My name is Marianne Fuglestved, and as you can see on the small flags above, I am Norwegian. And Norwegians always have to tell they're Norwegians. So I'm Norwegian, but I have lived all my grown-up life in Denmark. And I work in Denmark. I'm a psychologist, specialist in psychotherapy and clinical sexuology. And the past 5 years, I'm working in the Directorate of Prison and Probation in Denmark, developing and implementing R&R-based risk assessment and R&R-based supervision model. The risk assessment is both in probation and in prison. We have also developed an R&R-based program for prisons, but only as a pilot so far. So I will not go so much into that today. So yes, I do a lot of training of probation officers and managers. And my background is that I have worked as a clinical psychologist in what is called sexological clinic in our university hospital in Copenhagen, with all kinds of sexual treatment, but especially treatment for sexual offenders. And then later on, I was employed in one of our big treatment prisons, Herstedvester, where we treat sexual offenders. So that is my background for talking about this today. Yeah. And I have done some program development too. Yeah. So, some facts about Denmark. Denmark is a very small country. We are only 5.5 million inhabitants. Every year, usually, there are 2,000 to 3,000 reported sexual offenses, but only about 600, 650 lead to conviction. Why this is so, I'm not quite clear on that, but that's the numbers. And on an average, 28 persons are in supervision every day, who are also following sexological psychiatric treatment. So we are not talking about very big numbers. This is our treatment order for sexual offenders in Denmark. And I tried to make it all on one slide. I'll just explain very quickly that it starts from the least severe to the most severe here. In Denmark, it is possible to have, as an alternative to a sentence, you can attend outpatient sexological psychiatric treatment in a hospital unit with certain conditions. You have to be in community supervision. You have to start the period with 3 to 6 months in a halfway house. And there might be other conditions too, treatment for abuse, or there might be restrictions on where you can be, perhaps you cannot be with minors and so on. But this is only if you have an unsuspended sentence from 4 to 18 months. So it's not the very severe, not the severest group. Another precondition for getting this as an alternative to a sentence, a prison sentence, is that you are accepting that you have done the sexual offense, and you show some kind of motivation for treatment. So you have to accept that you would like treatment. And of course, only some do that, as we have heard. The most common, I think, when I think of the offenders I have treated through the years, is that they are denying or minimizing or neutralizing their offenses in some way or another. So the next is that if you have a prison sentence from 3 months to 5 years, you start your imprisonment in an assessment and referral unit in the prison Herstedvester. And here, the purpose is to assess your behavior. Is there a perversion? What is the problem behind your sexual offending? Is there a psychiatric problem also? And to motivate the person to accept sexological psychiatric treatment in an outpatient ward. I've been working in this unit, and I think about 1/3 of the inmates accept treatment after this period in the assessment and referral unit. So 2/3 go on doing the rest of the prison sentence in a half-open prison, but without any treatment. Because you cannot force treatment onto people. If they say no, they say no. So then they just go on with their sentence. And the most severe is when you have a prison sentence 5 years or longer, then you get your treatment, your sexological psychiatric treatment in the Herstedvester prison. There are psychologists, psychiatrists working there. And for a rather big part in this group, they will be offered anti-hormonal treatment as a possible treatment for them if they are ever going to get into the community again. So in all cases, community supervision can be or will be added at some time or at some point or another. Yes? There are questions to that? So, go a little quick. So what do we know about sexual offenders' risk needs? Carl Hansen has done this huge meta-analysis, and he said that there are 2 big major risk factors. And one is deviant sexual preferences, sexual preoccupation, as we heard earlier today. And the other is antisocial orientation, lifestyle instability. So we have these 2 big targets. And when I think about the period when I worked in Herstedvester in this assessment and motivation unit, I remember that many of the sexual offenders there were not pedophiles or did not have a perversion, but as we heard earlier today, were in a life crisis or had abuse or very poor social skills, low self-esteem, poor relational skills. And this antisocial orientation is not a target in our treatment, sexual psychiatric treatment. The antisocial part of their behavior is not included in that. They work with the deviant sexual preferences, but not the antisocial behavior. So my point is that I think it's a proper combination of sexological psychiatric treatment according to the deviant sexual preferences, and which is supplied with community supervision that works with the person's antisocial orientation. Bonta made this comparison. He compared the risk factors amongst general clients, offenders, and sex offenders. And there are considerable overlap, especially when you see antisocial personality, pro-criminal attitudes, criminal history, education, employment, and so on. So actually, Bonta says that working after the R&R principles, and I will get further into that, can be the appropriate treatment, actually, for sexual offenders, or for some of them. So, and Carl Hansen also made an identification of their attitudes towards sex amongst sexual offenders, and described them as being impersonal, like objectifying the other person, just an object for my desire, selfish. I only think about my own wishes, urges, needs. I don't think about yours at all. Adversarial. And when you talk with the sexual offender about his offenses, he will deny, or very often deny, that he has done something wrong, minimize the consequences, and have a lot of beliefs that permit non-consenting sex. So there are these attitudes have to be targeted and worked with to make the offender change attitudes and behavior. Now, denial is not a risk factor per se. And actually, denial is very understandable because sexual offending is not rewarded, not accepted, condemned in society and in prison. It is dangerous for sexual offenders to be in prison because what they've done is not rewarded. They are the lowest in the prison system. So denying what you have done is very sensible. And it can also be a sign that the person has some understanding of that his actions are not acceptable. If you, for example, compare it to, I don't know if you have been sitting and talking to a diagnosed pedophile who has no understanding of that he's doing anything wrong. That is a different feeling. He says it's okay. I'm helping these children. So, and that is not what we see the most. We see much more often that people are denying having done anything wrong. I see that as a self-protective mechanism. And you can work with this. This is a responsivity factor, not a risk factor. Please, if you have questions, just raise your hand. And so, now I will go on to talk a little about Mosaic, this supervision model. 5 years ago, in Denmark, we started to implement R&R principles in our probation system. And to do this, it was a political decision that we should implement R&R. So there was no choice. And of course, after having read and listened to James Bonter, we were very eager to do that too. But it was a political decision that now we're going to work according to the R&R principles. And so we thought, what are we going to do? We heard yesterday from Latvia how you have been working here, and it resembles some way our situation in Denmark. James Bonter said, how interesting that you want to work according to the R&R principles. I cannot help you because I am engaged in Sweden. And so are my colleagues. So I don't have the resources to help you in Denmark, but you are very welcome to use all my material. Come and attend our training here in Canada. But that's all. Okay. So we started to look into STICs, strategic training initiatives, in community supervision, which is the Canadian supervision model, and try to understand what that was all about, but also had some very good experiences with interventions from our own cognitive programs that we wanted to add on. And we were also very inspired by the Jersey checklist for interview skills for probation officers. So we learned a lot from other countries. And especially, I must thank Kriminalvården in Sweden for having been very patient with us and helped us a lot along the route. So this is how Mosaic was born 5 years ago. And as it is mandatory, all probation officers are trained in Mosaic. It's not something you can say, no, I'm not interested, or I don't want to learn how to make a structured assessment. You know, you have to make a structured assessment to find out who is low, who's medium, who's high. So everybody had to learn structured assessment, LS-R&R, and Mosaic. And in the beginning, I got a lot of punches on my nose, but now everything is going much more smooth. So in Mosaic, if we are talking about the theoretical approach, it is a combined approach where cognitive behavioral therapy, social learning theory, motivational interviewing, but also desistance theory work together in putting up the best suited interventions. So it's a combined approach, theoretical approach. And of course, what we first had to focus on was that working in this way with our clients in probation was a totally new role, both for the probation officer and the client. Because earlier, the clients were used to come to probation and sit down, set their bottom in the chair and wait for the probation officer to fix things. Yes, I have a lot of problems, blah, 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 blah. You help me, you do the work. So, as you see, the probation officer was really working. And there is, in Denmark, also a culture that, a social, helpful culture, where the probation officers really wanted to help. Yes, of course, I will help you. I will do this for you. Very humanistic, very And I don't want to demand too much from you, because that would be too much. I don't want to stress you. And in Mosaic, there is a totally new approach where there is a cooperation. The client has to be active in his own change process. He has to do the work. He cannot just sit down on his bottom and wait for things coming down. And the probation officer has a new role as well, starting to perhaps listen a little more to the client, training new skills, role playing. How can you manage this in your life, and so on. So it's a totally new role as a change agent for the probation officer, and that is quite a difficult task. Not for our new probation officers who come in and, yes, this sounds interesting and fun, and I know what I'm going to do, but for the probation officers who have been working as probation officers for many, many, many years, to them it is, it doesn't feel right. And of course, I can understand that. It takes a long time. Now, what happened here?
Should I do it?
Well, yes, we're there. Yeah. So my presentation was almost over in very quickly. We heard earlier that when we talk about sexual offenders, there is something positive combined or to their offending behavior. It has some positive aspects for the person, or else they would not go on being fixated into this kind of behavior. It gives them something very positive, as we heard this morning. So if we say that you have to be motivated for treatment to get treatment, then we're not getting anywhere. And that is not for sexual offenders. It's general, I think, for all kinds of offenders, that motivation for change is not there initially. There might be some extrinsic motivation, but not intrinsic. So when you work with change now for sexual offenders, you have to know that the person is losing something or is risking something. To change behavior feels risky. I might lose something. My life will not be that positive anymore, and so on. So motivation is something that you have to have in focus all the time, not only in the beginning, but all the time during the supervision period, and support the client's motivation. And of course, and this is for all medium to very high risk level clients, you have to make a relationship that is safe and where the client feels accepted and not confronted, but accepted. And at the same time, you can work with the criminogenic needs that have to be addressed, but it is urgent that the client feels accepted from the probation officer. So the probation officer cannot change anything in the offender. The offender has to change his own behavior. But what can the probation officer do? Well, you can always strengthen the client's strengths, address his strengths. For example, when you do an initial risk assessment, and you give the client feedback on his risk assessment, you will always start with telling him where his low risk areas are, because that are his resource factors. So you start with saying, oh, I can see here, you have a really supportive family. That is such a good thing to have if you want to make a change in your life, that have a family around you that supports you. So it's important always to show the client that there are strengths and possibilities inside himself and in his surroundings. And then this, slowly, you will see it in this video I will show just in a very short, that the probation officer tries to develop some discrepancy inside the client by looking at his strengths and values and goals, and then at the same time talking about his behavior. So what is the difference between your goals, your values, your wishes for your life, and your actual behavior? So in this discussion, some discrepancy develops inside the client, which can be the first motivational step for making a change in the life. Before we see this video, I will show you. I just want to inform you that Mosaic is built up as a stepwise learning model. We use this metaphor, which is a house for Mosaic, because the clients are supported by visual material. It's much easier for them to understand the steps they are going through in their supervision when they see it in a picture. So we use this house as a model to show the clients that first, in the soil is the risk assessment and the feedback on the risk assessment. In the foundation, we are talking about what are your values, what do you think about your risks and protective factors? And then the probation officer and the client set goals together. What are we going to achieve? And it's very important that the client is an active collaborator in this process. It is his goals. And then further up in the house, the probation officer introduces some interventions that elicit his pro-criminal thinking. And for that, we use an intervention called colors. This is from Sticks. And it is a very useful intervention to talk about attitudes without confronting or being impolite to the client. You know, attitudes are very personal. So if anybody goes in and says, your attitudes are wrong, then we're defending ourselves. And we don't want that. So this is an intervention that makes it possible to elicit, look at attitudes and discuss. Does this attitude bring me where I want? Or does it keep me stuck in the behavior I have now, which might bring me back to prison? And then in the roof, there is a training with behavior sequence, so where the client discusses critical situations he has been in together with the probation officer, and together they try to find alternative ways. And problem-solving skills are trained too. So this is the stepwise process all clients go through in Mosaic. The first thing probation officers and clients do is talk about what do we expect from each other. What do you think of being in supervision. And if the client has been in supervision, community supervision earlier, it is very important to tell him that this time you are getting the mosaic supervision model because you are medium to very high, you are on that risk level. So this time your supervision will be totally different. You have to be active in an active learning process this time. So now I hope you have patience to see a session where the probation officer is making the intervention My Values, which is in the foundation, the first step in the house. Yes.
Hi, Søren. Nice to see you again.
Yes.
Come, please. So, let's do a check-in like we always do. Do you remember the traffic light?
Mm-hmm.
Yeah. So, are you ready for today's session? And what color are you?
A little higher.
I'd say I'm green.
Yeah, green. Could you put a few words on why you're green?
Yeah, I feel good. I feel positive today.
Yeah.
I think, yeah.
Okay. So, how does it feel to feel good and positive?
Feels good and yeah, I like it.
Yeah, me too. Well, I'm also very positive today, and I would like to check in the screen as well. I really look forward to having this session with you. Last time was a good session, I think, and today we're going to have a very interesting topic. So I look forward to today as well. So great, really ready. Let's make a quick review of what we talked about last time. Do you remember what we talked about?
I think something about how we work together.
Yeah.
Yeah.
So do you remember what was important to us in our work relationship?
Yeah, something we are supposed, to be open.
Yeah.
Yeah. We like to be open.
Yeah. And I also remember you said something about being honest.
Yeah.
Open and honest. That was really important to both of us, yes?
Sounds right.
And you said also something about when I presented the mosaic model to you.
Yeah.
You said something, it was about school life. It sounded a bit silly to you.
Yeah. You don't remember me
Yeah.
back when I was in school.
Yeah.
I hated that.
Yeah. But have you thought more about it now?
Yeah. I think it's it feels better definitely than the last time I was in school.
Yeah.
Maybe differently.
Yeah. So you're willing to give it a try?
Yeah.
Good.
I think so, yeah.
Great. Today we're going to talk about values. And I will present an intervention for you called My Values. That means your values. But first I want to talk about what does values mean to you?
Yeah.
Have you been giving that a thought? What does values mean to you?
It's something that's important for me and for others.
Yeah.
Yeah, very important.
Yeah. So can you mention a value? We all have values, but
Yeah, like you said, like honesty maybe. And,
so it's important to you to be honest in this.
yeah, and kindness maybe.
Good.
Yeah.
So values, I can say, is something we all appreciate and aim for. It's not like a goal, but something maybe in the far distance. So we want to values can be personal, and we can change the way we live towards being more true to our values. We don't talk about them very often, do we? Do you talk about your values all the time? No, me neither.
No.
So, but since we aim for them, and it can be very life-changing to realize one's values, I like to present 30 cards that can symbolize values to you. And it's important for me to say there's no right or wrong answer. I'll just put them out on the table and take your time. Just look at the cards, see if they mean anything to you. And you can choose up to 3 cards. See if it symbolizes anything for you. I'll just put them out here. And I'll try to be quiet while you look at the cards.
Okay.
Maybe you can help me a little bit with
Yeah.
this. Thank you. Need more cards?
Yes, please.
Thank you. So, thank you.
Okay, that's a lot.
Yeah, just take your time.
Yeah, okay.
Look at the cards.
Yeah. I think I like this one. Yeah, what do you want me to do?
You can just hold your cards,
Okay.
take the 3 cards you like, and then hold them and we'll talk about them afterwards.
Okay. Okay, I think I have
You have 3
yes.
cards. Good. So just let's take all the other cards away, put them away so they're. So you found 3 values?
Yes,
Something that means something to you?
yes, yes. I think so.
Okay. These ones away. So which one do you want to talk about first? Which one means the most to you, or which one would you just feel like talking about?
You know what, maybe
That one. Okay. So I'll give you the sheet, and I know you like to write because that's what we talked about last time as well. So
yeah.
you write it down. So what is on the picture here?
So you know it's an old lady.
Yeah, an
And,
old
you know,
lady.
She reminds me of my mom.
Yeah. Tell me about that.
Yeah. You know, my mom is very important to me, and family, especially my mom, and because back when I was in prison, I haven't seen her for years. I haven't seen her for years before, and we always had a really good relationship when I was younger, but then things happened and I fucked up, and we did see each other really. But then when I went to prison, she visited me.
Oh, really?
Yeah, and I was really surprised that it was really. I felt really good afterwards, and it really showed me that you have to look out for each other, especially family is important.
Yeah, so you really
And
have
my mom, yeah, she's really important. I mean, that's the number one.
Right.
Yeah.
So, so responsibility, that's what I hear you saying, is
Yeah.
a bit important to you.
Right. Yeah. because-
Looking after each other.
Exactly. And I have to look after. I have to look after. I have to take care of her, right? And I have to be sure that she's well, and it used to be her when I was young, but now I think it's my turn, and it's very,
So giving back a
yes,
little bit.
yeah, exactly, yeah,
That's
yeah,
right.
because she's been there for me all the time when I was young.
Cool. So, we are thinking about what is the value? Can you find the value word like one word that describes your feelings towards your mother?
Maybe, I don't know, maybe gratefulness or, yes, you said responsibility.
Responsibility.
Yeah.
Let's write that down. Yeah.
Okay. Where's number one?
Where do you feel like it? Yeah.
Yeah.
Responsibility.
I'm not sure. Yeah, I hope I
It
spelled
doesn't
correctly.
matter. The sheet's for you. It's yours.
Okay.
So, you see on the red line here, it says why is the value for you.
Yeah.
So, could you just put down a few words why it's a value for you?
Okay.
Just like you just said to me before.
Okay. Yeah, we have, I think, in a family we have to look out for each other, and especially when we're close and use. I mean, my mom is so important, and I have to
Good
look
words.
after her. Yeah.
Write them down. Good, sorry. That will help us remember your value later on, yeah? So, we also need to ask you about how long has this been value for you?
Well, ever since the day she released me in prison, I think that's where it started.
Yeah.
3 years ago, 4 years maybe.
Write that down, that's, yeah.
Okay. I put 3 to 4, maybe.
Very good, very good.
Yes.
So I think in the next session we're gonna talk more about your other values. And it was so interesting for me to hear you explain that value. So are there times where you forget about your value, or is it present to you all the time in your life?
No, I forget that, there's been times where I forget everything, I just don't care. I don't care about anyone and anything, and it's just whatever. Whatever.
That must be very tough for you in the last few years.
Yeah, it's tough. I don't like it. I don't like it, but I don't know, but it's not, it's like just, it just comes over me and like a wave. I don't care.
So when you talk about your mother, you get close to you. So how does it feel when you know what's important to you, you actually live after your values like your mother, when you look after your mother? How does it feel? How does it feel?
Well, it feels good, it's something I can, it feels like it's something I can hold on to, and it's, especially when I'm down and I feel like, just, whatever, and but then I think about, my mom, and then she just kind of, it helps me,
So when you want to look after your mother, it also gives you some sort of responsibility. What do you need to have in your life, and what have you accomplished since you've been released from prison that will help you look after your mother?
Well, I used to hate other people, but, I really tried to meet with other people. I mean, I got a job recently.
Job,
Yeah,
nice.
and I really like my colleagues. I mean, it's nice to be around them, and I can share things, and then it feels like there's more things, that positive things.
So that's taking you in a positive direction. So what do you think it has to do with you risk offending again?
I don't know. I mean, I would hope it's not that big of a risk anymore. Yeah, I mean, I think my mom would be really, she would be disappointed, if I was to, go to prison again.
So then it's actually much better when you follow your values. You're taking care of your mom, you have a job. Don't do crime anymore.
Wow.
So this was a short demonstration on this intervention, which is a pro-social anchor for the client's change process. You can always go back to the values because it's the client's values, and ask him, in the way you behave right now, are you going towards your values or against them? So involving the client as much as possible, using a session structure that is recognizable for him and gives him an overview and control over his own process is very important. I often see that when clients come in and there is not a clear session structure, the client gets defensive at once because they don't know what is going to happen now. So a clear session structure is very important. Visual material that the client can work with actively, stepwise learning, link behavior to attitudes all the time, and practicing new skills, homework and positive reinforcement. So a mosaic session is usually 45 minutes, not more, not much less either. Of course, there can be clients who have responsivity issues, ADHD clients, for example, where you have to shorten the sessions. This is a short session. And this is the structure we always use. It is always taken from sticks. So after the client has done this work with his values, he assesses his own risks. What do I consider my risks are? In 3 months, the next year, 5 years or more, what increases my risks? And what will protect me from reoffending? And I mean, when the client tells the probation officer, what can keep me close to my values and avoid reoffending is, for example, when I am in a job situation, for example. And this is very valuable information to the probation officer. We are given the solution, actually. So after this process, the client and the probation officer set goals together for the rest of the supervision period. What are there any conditions for your probation period? For example, do you have to attend treatment for abuse? What are your risk needs that we have to address during this supervision period? What are your long-term goals and what are your short-term goals? And all this is written down and visited along the supervision period. This is the intervention colors. As I said, it is a way of talking to the client about attitudes in a non-confrontational way, where you say, you explain to the client that there are 4 typical attitudes we can have in different periods of our lives. And when we explain this to the clients, they always end up saying they are green or they want to be green, which is the most positive way, the most positive attitude if you want to avoid conflicts or new offending behavior. So Mosaic is really supporting the pro-social potential in all clients. So slowly, dissatisfaction around one's own behavior comes in front, and some recognition that failure is not an accident. It's not because I'm addicted. I can get in control with my behavior. It's not an accident. My behavior is a result of my attitudes, and I can change my attitudes. And then ordinary training with behavior sequence. I don't know if you know this from CBT training, where a critical situation is analyzed and where the client finds new pro-social alternatives to his pro-criminal attitudes and behavior. So there's always a choice. There's always an alternative. And what are your values? What are your goals? So is your next step if you want to go into that direction in your life? So I will end this now. The probation officer's opinion on Mosaic that it is a good way of working. That is what almost everybody says now. They like the work together with the clients. The clients are getting much more active, and they're actually now turning up to the sessions. And it gives a uniform content regardless of probation officer and regardless of the client's offense. It's the same approach to all clients. So thank you for your attention.
Thank you, Marianne. So we've got a few minutes for maybe one or two questions. Does anyone have any questions that they would like to ask Marianne about what she talked about today, or points of clarification around Mosaic, or maybe some of the challenges or benefits of it?
Do you think some of it could be, yes?
Hold on.
First of all, thank you, Marianne, for that presentation. Do you think Mosaic has had a positive effect on reconviction data? Do you have any data that compares the present way of working with how you worked previously?
No.
Oh, that was the wrong question. Okay.
Next
Because
question.
It
No.
sounds really positive, and
Yes,
that
yes.
should work.
First, we did not make a baseline measure before we started, so we don't, unfortunately.
Okay.
So we cannot compare it to anything, if you understand. And the effect on recidivism is not very secure yet.
Okay.
Also, there is a 2-year period always after probation where you look at the risk of reoffending, recidivism. And from that, the clients who are that far were the starters in Mosaic. And at that time, the probation officers had very little training. So I think there will be a long time before if we can ever see an effect, actually. But we are saying as it gives meaning to the probation officers. They like to work in this way, and the clients are much more active. I mean, I have seen 200 videos of Mosaic sessions with probation officers because I should give feedback to the probation officer on his skills, and I can see active, positive clients.
There would be less breach action then,
Yeah.
taking clients back to court for non-compliance. That's a very promising result, isn't it?
That too.
Yeah. Thank you.
They're actually following their
Thank you.
supervision.
And time for one last one.
I think most of the people in this room will hate me after what I will say. But I very liked your presentation. They will not hate me for that, I'm sure. I believe this is the future. I think it's very important that we use some kind of tools during our interviews with clients, that we just not talk with them and they sit and listen, or we listen to them, but there's some activity involved into it. And this high structure is also indeed very important, also from our experience in Latvia. In Latvia, for the last 15 years, from the very beginning, we have a strong focus on R&R model. We are assessing risks, we develop resocialization plans, we try to engage clients similar way as you are doing in preparation of those relapse sentence plans, not relapse prevention, but sentence plans. But you will hate me for this. I believe risk-need responsibility is a very efficient model, but I'm very bored of it. It's I'm sorry, but I think it will die in natural death. It will become a golden classic. We'll leave its legacy, and we will move forward more towards this strength-based approaches. When we, instead of more focusing on criminogenic needs, we'll find a way how to focus more on resources and his own engagement into process, and it will happen step by step. And I see this your model as a very good step towards this direction, which also helps a lot probation officers. They live in less hostile environment at their workplaces. The relationships and the dynamics of relationships with offenders is much more positive, in my understanding. And they are not so, I remember from my own experience when your clients, for example, do some bad things. And some do suicide, some is killed, some do reoffense. And then, of course, you ask yourself whether this was my fault as a probation officer or that somehow else, the process was organized. But if your whole model of your community supervision is based on responsibility of community's probation officer, of course, it's very difficult for him to get out of this situation. But when offender is engaged by himself and you are trying to put this emphasis more on his own responsibility and understanding of the situation and moving through it, then you also reduce risks for your own staff, in those bad situations.
Absolutely. And also I want to say that Mosaic is a training in having a relationship with a professional. To go into a cooperation with a professional person, and which is very important for these clients because they have to work with job centers and so many other professionals. So this is a way of training them in being active and taking responsibility in these situations.
I'm really sorry. You can finish it afterwards. Yes. We started with love and now it ends with hate. It wasn't the aim of the conference, but no, I think you've inspired a lot of conversation and reflection, and hopefully this will continue on outside of this room. I'd just like to quickly hand over to Wilhelm, who has a gift.
Oh, thank you so much. Thank you so much.
Thank you. So now comes the ending. And I don't think this is about endings. Hopefully, this is about the start of conversations. We work in a field where collaboration is key. It's the most important thing that we can do is learn from other people's good practice and learn from our own and other people's bad practice. That there is a lot to be learned from conversation and collaboration. And one of the strengths of this conference, just to throw some numbers at you, we've had over 120 people from 20 different countries. We have had 14 speakers from 8 different countries. We have had probation, we have had therapists, we have had counselors, we have had police, we have had academics. And when you go to conferences, quite often you find yourself siloed. Everyone's a police officer, or everyone's a probation officer, or everyone's a therapist. And we work in a multidisciplinary shared field where we have to think about the public, and we have to think about the state, and we have to think about policy and how we form policy and how we work together. We have to think about health and treatment and management and punishment. So we all need to come together. And my reflections are that this conference did a very effective job of this. We got to meet people from other countries who are at different points on their journey and have learned and reflected upon different things. But also we've had a range of talks that have gotten us from maybe adverse childhood experiences, the background of people who perpetrate, how we think about the range of perpetration, whether it's online, whether it's offline, whether it's contact, how we think about developing policies for this, the ways that we think about treatment and management and how that reflects daily practice. And I think it's given us a lot of food for thought to take away and to really consider where we go next. I feel it's quite ironic that under the guise of Brexit, and that, you know, I sort of feel I need to say that we're talking about conversations about dissolution, and this conference really showed that we're better together. We're better collaborating and moving forward together. Hopefully you've met some future collaborators. Hopefully you've met some future friends along the way. I know that I have. 18 months ago, when a man emailed me and said, can you come and do this? We had hopes, but I think this has been a success. And a lot of that is down to you for coming and talking and keeping an open mind. I hope you have some really positive things to take back, and I'm sure we'll see each other again at some point. I'm going to hand over to Wilhelm to do the formal closing, because I always forget names, and it's not my strong suit, and he is skilled at this. He's even got paper. Yes. Thank you very much. Thank you for coming, and safe travels.
Okay. Ladies and gentlemen, my finest hour. But we have come to an end of an intensive program, and before closing the conference officially, I now have the pleasure of sharing with you some thoughts of the main messages. Kieran already addressed some that have emerged in the course of this event. And I'm very pleased that so many of you, and we counted 120, but I counted 19 different countries. You probably counted Northern Ireland as a country, separate country too. Yeah, of you have here come together here to discuss the important issue of the management of sexual offenders, and we call it Reframing Sexual Abuse Practical Directions. And over the past 2 days, we have enjoyed some excellent presentations from a wide variety of participants and nationalities. Best practices on management of sexual offenders were shared in the workshop, and interesting discussions took place, and opinions were spread in the roundtable session. And it helped us, I think, to make an important footprint for the future for probation practice. For me, it was very special to learn more about the practical but also ethical difficulties some professionals and organizations face in working with sexual offenders in daily practice. Although much has been achieved, there is still much to do to improve the position of sexual offenders as well as the victims. I also learned that special attention should be given to the position of the probation professional too. Ladies and gentlemen, I believe the representation this conference has attracted is an encouragement sign for the commitment of all relevant parties in the field of management, treatment, and research. Fortunately, there was a lot of opportunity to meet and to talk with peers and exchange information and best practices. And I encourage you to stay in contact and exchange information and knowledge about management, treatment, and practice, and of course, relevant research regarding this specific group of offenders. We all need to grasp opportunities like this, I think, not just to make the most of this event, but more importantly, to ensure that the benefit we get from this conference continues to add value to all of our own daily practice, and particularly in how we deal with the position of offenders and victims. I hope that you will agree that this first conference on management of sexual offenders was a success. I also hope this conference will be an inspiration for further development of practice in a broader sense, and all participants, I think, should be proud to be part of this effort. I think it's also a tribute to the high-quality recruitment process for this occasion done by the CEP expert group. Audrey, Kieran, Mike, Imans, Brian, thank you. They succeeded in putting together a good program, and attention individual has given to the papers and presentations. Ladies and gentlemen, I would like to thank Director General Mihails Papsujevis for inviting CEP to come again to Riga again. I also like to thank Imants Eurovisius and all his colleagues from the Latvian Probation Service for organizing and hosting this conference. I'd like to thank all plenary speakers for their excellent presentations. Their contributions helped us to identify the importance of understanding, research, and practice in the process of rehabilitation and reintegration. I also would like to express my appreciation for the workshop leaders for their contribution and high quality of the presentation. And as you know, I will repeat it, all presentations and documents contributed to the workshops and the plenary sessions will be available on the CEP website soon for your reference. But of course, I also want to comment and thank all participants for their active contribution. You, as experts, met at one place and shared related problems. You jointly examined practical ways and means to solve problems. That was great and rewarding to see. I'd like to thank the colleagues from the Latvian Probation Service who are behind the scene. They're also important. And our delegates enjoy the translators, and translators seem to enjoy the conference as well. Translators knew exactly what to do and when. Thank you for your excellent job done. And finally, I like to thank my CEP staff. Marinte Bos, where is she? Here, okay. Maria, she's sitting over there, and of course Miriam. So they worked so hard to make this conference a success. Many delegates have asked me if and when there will be a follow-up on this conference. Yes, there will be. No, I don't know when. But perhaps a good opportunity will be when the Council of Europe has finalized the guidelines on management of sexual offenders. I will keep you posted on that. My last sentence. Ladies and gentlemen, although we have been here just for 2 days, I'm sure all of us will carry very happy memories to the beautiful city of Riga. And ladies and gentlemen, on behalf of the Latvian Probation Service and the Confederation of European Probations, once again, I thank you very much. Have a safe trip home. Don't forget the evaluation.